Hi everyone, myself Dr. Bhavik Champaneri. I am a pediatric cardiologist at UNMICRC Institute of Cardiology and Research Center. Today I will be talking about common transcatheter interventions which is being performed for congenital heart diseases. So this is my overview of a talk. So I will be talking about various types of procedures being performed, specification of various devices, individual procedures, its indications, steps and examples. So these are various procedures which are being performed for a treatment of congenital heart diseases via a transcatheter approach. These are septal defect closure, that means atrial septal defect or ventricular septal defect device closure, abnormal vascular connection closure in the form of PDA device or coil closure, various fistulas and collateral device closures. Balloon dilatation procedures include balloon valvuloplasty procedures which are like balloon aortic valvotomy, balloon pulmonary valvotomy, balloon mitral valvotomy, or balloon dilatation of coarctation of aorta and various other procedures and various miscellaneous procedures. Among this list, these are a common transcatheter interventions which are being performed for congenital heart diseases that include ASD or VSD device closure, PDA device closure, balloon valvuloplasty procedures like balloon aortic valvotomy and pulmonary valvotomy, and balloon dilatation of coarctation of aorta. So I will be talking and catering this common group of interventions which are being performed. In addition, many complex variety of transcatheter interventions are being performed for congenital heart diseases which I am not going to take or cater in this talk. So these are the common devices. So this you can see in the screen is an atrial septal defect device, occluder device, which is called Emplitzer septal occluder device. This device, as you can see here, it has a two disc, one disc on this one which lies on the left atrial side, and this is a disc which stays on the right atrial side, and the device size is decided based on the size or a diameter of the central waist, and it is in the range from 4 mm to 40 mm sizes are available. This device, as you can see, it's a metal device, it's made of a nitinol mesh. It has two membranes inside. These are a PTFE membrane to allow clotting of the blood. So here you can see is a atrial septal defect device, septal occluder. These are common devices which are being used for patent ductus arteriosus. This is the most common device which is being used for patent ductus arteriosus and which is called ADO1 device. This is again made up of nitinol mesh and it contains PTFE membrane inside to allow clotting of the blood. This is a single disc device. As you can see, there is single disc on which stays on the aortic side of PDA. This is another device which is called ADO2, Emplitzer duct occluder type 2. It is a double disc device. And the advantage of this device is it's a low profile device. It goes through a smaller diameter catheters and sheath, and you can occlude the ductus, patent ductus arteriosus using this device. This device does not contain PTFE membrane because it contains very closely knit nitinol fibers, nitinol mesh. So the mesh itself allows clotting of the blood, so it does not require any PTFE membrane. Similarly, this is a special device which is available for preterm PDA closures, which is called Piccolo device. Previously it was known as ADO2, Emplitzer duct occluder 2 AS, additional size device, which is now given the name of Piccolo device. Again, as you can see, it's a 2 disc device. This device comes in various sizes and depending on the anatomy of ductus arteriosus, various devices are being used. This device is extremely low profile and it goes through a 4 French sheath, and with this device there are multiple data available where occlusion of patent ductus arteriosus has been performed in preterm babies as low as 800 gram and 900 gram weight. So these are the various devices which are being used for closing ventricular septal defect, and again these devices are the devices which are used for patent ductus arteriosus, that is ADO1 and ADO2. ADO1 and ADO2 are the most commonly used devices for closing ventricular septal defect, most commonly perimembranous VSDs. This is a muscular VSD device which is being used for closure of muscular septal defects where there are margins available on all the sides of a defect. These are the various, this is a balloon, most commonly used balloon. It is a non-compliant balloon which is called tie-stack balloon, and it's a this again is a low profile balloon, and it is being used for valvuloplasty procedures like balloon pulmonary valvotomy and balloon aortic valvotomy, and again it comes in various sizes ranging from 4 mm to 23 or 24 mm in diameter. So coming to PDA device closure, these are the indications of PDA device closure that includes PDA with signs of LV volume overload or a PDA with continuous murmur. Silent PDAs usually it's not indicated, and it's usually it's not advisable to close it because it's hemodynamically very insignificant. Age criteria, usually it is being done after neonatal period because it has been documented that till neonatal period at any day of life there has been documented closure of patent ductus arteriosus by itself. So it is always better if you wait it out till 1 month of age. Weight criteria, it's usually done above 4 kilogram of the weight, but it's not a strict criteria, as we have discussed that preterm PDA devices also have come where people are doing PDA device closure in as low as 800 gram and 900 gram of weight. In neonatal period, as I have told, neonatal period it is avoided because it can spontaneously close. In neonatal period, if child is very symptomatic and significant failure symptoms, you can consider closure of those patent ductus arteriosus in neonatal life as well. So this is a diagrammatic presentation. As you can see, this catheter has gone from femoral vein into inferior vena cava. It has gone through right atrium, right ventricle, through pulmonary artery. The patent ductus arteriosus is crossed, and the patent ductus arteriosus is being occluded with this device, which is Empletzer duct occluder type 1. So similar, this is a case example. It's a 3-month-old child whose weight is 4 kilo. See, the child is having a history of recurrent respiratory tract infection, and as you can see in a 4-chamber view, LA and LV is significantly dilated, and in ductal view you can see there is that red flow. The ductus arteriosus is patent and it is flowing left to right. So patient was taken for cath lab. The femoral arterial approach is taken, and through the catheter the arch angio or a ductal angio is being performed, and as you can see here, this is a patent ductus arteriosus filling the main pulmonary artery, and in the fixed image this is a patent ductus arteriosus being filled in ductal angiogram. So patient from femoral venous side, this sheath has been advanced through the ductus arteriosus into the descending thoracic aorta, and as you can see, this device is being deployed across the ductus arteriosus, and this is a post procedure angiogram showing as comparison to pre-procedure angiogram. This is a pre-procedure angio showing patent ductus arteriosus, and post device occlusion, this is an angiogram showing near complete occlusion of ductus arteriosus. This residual flow, as you can see here, it goes away over a period of some time because it will the blood will clot in a PTFE membrane, and it will occlude the residual flow completely over a period of time. So this is a pre-procedure angiogram showing patent ductus arteriosus, and similar post-procedure angiogram showing device well placed across ductus arteriosus in ductal view, and there is minimal residual flow, as you can see here, through the device, which will occlude eventually within 1 to 2 hours post procedures. So this is an example of a 2-month-old child whose birth weight was 1.7 kilo, and there is no weight gain. His current weight is 1.8 kilo, and the size of a PDA was around 2.5 mm. The patient was taken in cath lab with an idea to occlude the PDA with ductus arteriosus because it was a genuine indication, because patient was having significant failure to thrive, and this is an angio through the venous sheath parked across the ductus arteriosus, and angio is showing that this is a ductus arteriosus here, which is more of a tubular ductus arteriosus, which is a common anatomy in preterm babies, and the same defect or the same ductus arteriosus is being occluded with a device which is specifically designed for preterm babies, which is Piccolo device, initially which was known as ADO2 additional size device, and here the ductus arteriosus is being occluded with the ADO2 AS device, and the procedure went successful. This is another example where patent ductus arteriosus is being occluded with a coil. Here the coil is being captured by a bioptome, and through the bioptome coil is being deployed across the ductus arteriosus, completely occluding ductus arteriosus. So coming to the next device closure which is being performed commonly is an ASD device closure. Guideline again, usually it's always ostium secundum ASD, ostium primum ASD and sinus venosus ASD cannot be device occluded. Although recent advances, sinus venosus ASDs are being closed by placement of covered stand from SVC to RA, which is still under evolution, and usually ostium secundum ASDs are being closed with the device undergo the device closure. Ostium primum ASD cannot be device closed. Ideal age for ASD device closure is more than 3 years, although some people are doing in less than 3 years, around 2 to 3 years of age. Ideally it is better to occlude the atrial septal defect with device by after the age of 3 years. Ideal weight would be less than about 2 to 10 kilos. Again, these are ideal scenarios and not necessary that it is a strict criteria. This is important, device size should not exceed 1.5 to 2 times of the weight. Suppose the baby's weight is 10 kilo, I would be worried if I am putting a device which is more than 20 mm. Up to 20 mm you can still consider. It would be safer to put a device which is less than 20 mm, because you may end up in some sort of complication like complete heart block because of oversize of the device, or you may sometimes end up with erosion of heart and cardiac tamponade or something like that, or erosion of aortic root. So this is a normal anatomical understanding of atrial septal defect. This is an atrial septal defect in en-face view. This is an entire atrial septum, and as you can see, this is how we nomenclature for individual atrial septal rims is being given. And as you can see, this rim in IVC is called IVC rim. The rim towards SVC is called SVC or a SVC rim or a postero-superior rim. IVC rim is also called postero-inferior rim. The rim which is on superior aspect and more anterior aspect is called aortic rim. The rim towards AV valve is called a mitral rim or a AV valve rim, and the rim which is exactly opposite side of a mitral rim is called a posterior rim, which extends from superior vena cava to inferior vena cava. And based on adequacy of this rim, we decide whether this ASD device is possible in this patient or not. And usually IVC rim, when it is deficient, these are the patients who may not be amenable for device closure. So the rims which is very important for successful ASD device closure include IVC and mitral rim or AV valve rim and posterior rim. So these 3 rims are very important, and assessment of this rim is very important when you are planning a patient for ASD device closure. Superior rim deficiency is very common and has been done successful. ASD device closure is being done successfully in patients who have deficient superior rim or a deficient aortic rim. So indication: right atrial and right ventricular enlargement by echocardiography with or without symptom. ASD diameter should be more than 5 mm. Small ASD and PFO, if there is documented paradoxical embolization, then it may be an indication for closure, and rim should be adequate. Usually it should be more than 5 mm. Again, aortic rim deficiency is not in a criteria. Most of the people or many of the cases which we are doing ASD device have deficient aortic rim. Most important rim is IVC and mitral rim, and it is always desirable to have IVC and mitral rim which is more than 5 mm. So this is a diagrammatic presentation of ASD device closure and how it looks. This catheter has gone from IVC through RA, and we go into left atrium, and this is how the device is being deployed across the atrial septum, and this is how the device captures the atrial septal rim, and the device remains in its place. So this is an example. It's a 4-year-old child, weight is 12 kilo, diagnosed to have large ostium secundum ASD, and the size measured was 14 mm. Here you can see the defect in a 4-chamber. So here this is your mitral rim, and opposite of mitral rim is your posterior rim. So in this patient your mitral rim and posterior rim is adequate. Again you can see right atrium and right ventricles are dilated, ASD is exclusive left to right. This is a bicaval view where you can see your SVC rim, which is on a superior aspect where SVC is there, and this is your IVC rim. So this is a patient where your IVC rim, SVC rim, mitral and posterior rims are adequate. So this is an ideal candidate for a device closure. Patient underwent was taken into cath lab and underwent a ASD device closure. The device of around this defect was closed with 18 mm atrial septal occluder, and this is how post deployment, this is a device deployment sequence. You can see the device is LA disc is opened and gradually device is pulled, and the device is deployed across the atrial septum, and this is how it appears in anteroposterior view after device deployment or after device release. Both the rims lie on each other like an en-face view. So this is a pre-procedure echocardiogram, and this is a post-procedure echo showing how device appears post-device occlusion of atrial septal defect in 4-chamber and in bicaval view, showing complete occlusion of the shunt and the well placed device capturing your atrial septal rims. So this is a 9-year-old child who had 2 atrial septal defects. These are very rare patients where we do come across such sort of anatomies, and we are forced to close these 2 ASDs with 2 different devices, 2 separate devices, and that is how the 2 defects has been occluded with 2 separate atrial septal defect closure devices. This was a very rare case, 4-year-old child who had 2 episodes of stroke and came to us with loss of vision on the left eye and was diagnosed to have a PFO. So this was, as discussed earlier, it was an indication for PFO device occlusion or occlusion of a PFO, because there was documented history of 2 strokes with loss of vision on the left eye, and this patient underwent device closure of PFO with ADO2 device. It's a device which is being used for closure of PDAs or VSDs, but in this rare case, because the child was overall small and ADO2 was also seemed to be adequate to close this PFO, and this child underwent PFO device closure with ADO2 device. So coming to next transcatheter intervention, it's a VSD device closure. So red flag, large VSDs and VSDs which are very close to aortic valve or pulmonary valve cannot be devised. Indications include small to moderate VSD with LV volume overload. Ideal age again would be more than 3 years and more than 10 kilo of weight. Again, these are not strict criteria, but it is better if you stick to such criteria for the safety of the patient. So this is an example of a muscular VSD, and this is a diagrammatic presentation where my catheter has gone from IVC through the femoral vein, IVC, RA, RV, and through the VSD we have gone to left ventricle, and this is a device being deployed. This is a muscular VSD device being deployed across the muscular VSD occluding the ventricular septal defect. So this is another example. It's a 7-year-old male child, weight of 16 kg, and was diagnosed to have moderate size perimembranous VSD. Size was around 4.5 mm. As you can see, there is significant LA-LV volume overload. So it was obviously an indication for VSD device closure, and patient had symptoms of recurrent RTI as well. This is a 5-chamber apical 5-chamber view showing ventricular septal defect with left to right shunt, and this is a cross section view where defect measured around 4.5 mm in size. So patient was taken in cath lab. This is an LV left ventricle angiogram through the aorta. Pigtail is placed in the left ventricle. Angiogram showing your perimembranous VSD which shunt left to right with significant filling of right ventricle. Patient and this is a procedure. This is a image showing the deployment of the device across the ventricular septal defect. It's an ADO1. It's a single disc ADO1 device The size of the device was around was 10 by 8 mm, and this is a post procedure LV angio showing complete occlusion of the ventricular septal defect by ADO1 device, and eventually the successful PDA VSD device closure was done. This is a pre-procedure echo and this is a post-procedure echo showing device in good position with no residual flow across the device. This is another example. 4-year-old child had diagnosed to have dilated LLV and posterior muscular VSD, and this defect was closed through the arterial side through the guide catheter. A 5 or 6 French guide was used and ADO2 device was used to occlude the ventricular septal defect, and angiogram showing a complete occlusion of ventricular septal defect with ADO2 device. This is a pre-procedure echocardiography showing a 4 mm posterior muscular VSD, and this is same patient after occlusion of the defect with ADO2 device, completely occluding your ventricular septal defect. This is a case report was published in 2017. This was a 1.8 kilo child or infant who had already undergone PDA ligation, and he was having a perimembranous VSD, but because patient was very sick, post PDA ligation there was residual PDA and there was a perimembranous VSD in addition to that. So both of that residual PDA and VSD was giving rise to significant hemodynamic difficulties, and we were unable to wean this patient off ventilator, and because of that patient was taken into cath lab, and this is how the VSD is being occluded with ADO2 additional size, or recently it is known as Piccolo device. So PDA was also closed with Piccolo device and the VSD was also occluded with the Piccolo device. So both the residual lesions were occluded with Piccolo devices, and eventually we were able to wean this patient off ventilator and came out of ventilator, and patient has been doing well. Coming to balloon pulmonary valvotomy procedure, the indication is critical valvular PS, that means severe PS with cyanosis or RV dysfunction. It is an indication for immediate balloon pulmonary valvotomy. Severe PS where gradient is more than 50 mm mercury, and moderate PS if patient is symptomatic. So here it is a diagrammatic presentation where our catheter goes through the femoral vein into IVC, RA, RV, and across the pulmonary valve we inflate this balloon, and post inflation we take out the balloon. This is how the balloon pulmonary valvotomy procedure is being performed. This is an example of 14-year-old girl who had dyspnea on exertion. She is having functional class 2 symptoms, is having severe pulmonary stenosis with gradient of 80 mm of mercury, as you can see in this Doppler. Patient was taken into cath lab. This is a lateral projection where end hole catheter is taken into right ventricle through femoral vein, RA, IVC, RA and RV. RV angio is being performed, and this is how the doming pulmonary valve look, and we measure the pulmonary annulus here, and the balloon pulmonary valvotomy procedure is being performed. Here you can see the balloon being performed and the waste being disappeared, giving rise to significantly reduction in pulmonary valve gradient. As you can see, post procedure echocardiogram showing a gradient of around 25 post balloon pulmonary valvotomy procedure. So coming to next procedure, balloon aortic valvotomy. Bicuspid aortic valve with severe AS is an indication. It can be critical where LV is down or duct dependent systemic circulation. It is an indication for immediate intervention. Severe valvular AS where gradient is more than 50 mm of mercury. Valvular AS with moderate, which is moderate but patient is having symptoms like effort angina, syncope, or patient is pregnant and there is ECG changes on exercise. Usually BAV is not being performed when gradient is less than 40 mm of mercury, because you may end up with some degree of aortic regurgitation post balloon aortic valvotomy. So we try to extend whatever maximum possible time by avoiding BAV if the patient is not a genuine indication for balloon aortic valvotomy. So for balloon pulmonary valvotomy, the size of the balloon usually being selected is around 100% to 120%. That means if the annulus of pulmonary if the annulus of pulmonary artery is 10 mm, usually the balloon selected is at least 10 to 12 mm balloon being used. So for similar way, for balloon aortic valvotomy, we undersize it because we don't want to end up in aortic regurgitation, and that's why the balloon being selected is 80%. So if the annulus is 10 mm, we will try to use the balloon dilatation balloon of 8 mm, and if there is significant residual gradient, we may go up to 10 mm, but we usually don't go above 100% in case of balloon aortic valvotomy because we don't want to end up with severe aortic regurgitation. So this is again a diagrammatic presentation where through femoral artery catheter has gone and balloon is taken across the aortic wall and balloon is being inflated to open up the stenotic aortic valve. So this is a 2-day-old child who came with critical valvular AS, severe LV dysfunction, and was duct dependent. Patient was on prostaglandin, was taken on emergency basis for balloon aortic valvotomy. This is an aortic root angio showing doming aortic valve with very narrow jet, as you can see, very narrow washout jet showing critical aortic stenosis, and the Tyshek balloon is being taken and balloon is being inflated across the aortic valve, reducing your aortic stenosis, and that is how patient gradually improves over a period of time, and you can stop prostaglandin infusion because it was a duct dependent circulation. So coming to balloon dilatation of coarctation of aorta, usually indication for neonatal life, surgery is the first option. Balloon dilatation can be done if the patient is very sick and you want to bail out this patient and buy some time. Infancy, surgery is again better option, but balloon dilatation can be preferred if there is post-operative residual coarctation of aorta, and many centers nowadays in infancy balloon dilatation of native coarctation is being performed as a primary approach. And childhood, balloon dilatation is the first option, or sometimes we may have to do stenting of coarctation of aorta as well. So this is a diagrammatic presentation. Here you can see it's a coarctation of aorta and balloon is being taken through the aortic through the femoral artery, and balloon is being inflated across coarctation of aorta. So this is a case, as you can see, it's a 2-month-old child who has already undergone coarctation repair through thoracotomy procedure, but has come after 1 month of life, after 1 month of procedure with severe recoarctation of aorta. Coarctation was so severe, we were not able to feel the femoral artery pulses, and this patient, as you can see, this catheter is coming through axillary artery. We took axillary artery approach through axillary artery. This is an angiogram showing severe tight coarctation of aorta post subclavian, left subclavian artery. In this image you can see the balloon has taken across the coarctation segment and balloon is being inflated across the coarctation segment, and this is a post procedure angiogram showing well open coarctation segment with almost no stenosis, and the gradient across coarctation became nearly normal, somewhere around 10 millimeter of mercury. So this is a red flag because it's always tempting to do transcatheter interventions, but you should know that complication can happen during any intervention. So you have to be very vigilant to avoid any complication. Technically, after some time of training or some exposure to the transcatheter intervention, it is relatively easy to perform the transcatheter intervention, but you should what is more important is a proper selection of patient. Planning the procedure and knowing when not to do the intervention actually makes you interventionist. So it's not always to jump over to do transcatheter intervention. You should plan, you should select your patients properly so that you can avoid complication, and you should know that when you should not do intervention, surgery is safer for these patients, actually makes you interventionist. Thank you.